Hello, my name is Betty Paziri Mandihol. I'm BHMS student from OUMKK. Today I will present a case of the management of a pre-hospital case, patient with ischemic cardiac chest pain. Okay, according to the Watson 2021, chest pain or anginas caused by insufficient blood flow to a portions of your heart and pressure or squeezings in your chest might mimics of a heart attack. That known as a ischemic chest pain, ischemic cardiac chest pain. It was a sign of heart disease that occur when your artery are blocked or there is a insufficient blood flow in artery that supplies oxygen's rich blood to your heart. Okay, in these sections, I will present a case, the management of pre-hospital care patients with ischemic cardiac chest pain, and this is also includes the chronological management and how team member pre-hospital care respond a case of a chest pain, emphasizing the role of interprofessionals team members in operating to deliver well-coordinated care and improve outcomes for afflicted patients. Okay, let's start.
Okay. A 50-year-old man that lived alone called hospital run now complained about chest pain. As a pre-hospital care activations that receive call, a team respond that case. And during arrival, vital sign has been taken and BP was 160/92, pulse was 112 beats per minute. It's strong and regular. Respirations was 22 per minute and unlabored, and oxygen saturations 97 on room A. Patients have a sign and symptom of chest pressure, restlessness, diaphoresis, tachycardia, hypertension. From the history taken, patient said that it began suddenly and it woke patient from sleep about an hour ago, and the pressure in his chest is constant and nothing that he does makes it better or worse. He said that his chest is felt very tight and it stayed there, not radiated anywhere, and from the physical examinations, no sign of trauma on chest and chest wall is symmetrical and no tender. Breath sounds clear and equilateral to auscultation. Jugular vein is normal and not distended. Patient claimed that he pain score scale to 7/10. And ongoing assessment, patients in ambulance head to emergency department. Patient conscious and alert to persons, place and time and less restless. Patient aware remain pattern. Respiratorants are 20 per minute and unlabored. Oxygen was 99 on nasal prong. Vital sign checks and blood pressure was 130/84. Pulse was 88 beats per minute, strong and regular, and cardiac monitor saw ECG was normal, sinus rhythm at 90 beats per minute. Patient pain score was 3/10 scale after given 2 mg of morphine sulfate via IV push. Actually received call at 6:37 a.m. and 6:40 a.m. Our unit is dispatched for a 50-year-old male with chest pain. The team proceed to the scene with a response time of approximately 8 minutes. The closest hospital from the scene is 40 miles away. At 7:05 a.m. arrived at the scene, do appropriate scene inspections, precautions, and ensure that the area is safe. Then knock on the doors of the patient residence. A middle-aged male answered the door and identified himself as the patient's. You note that he is diaphoretic and anxious and clenching his fist against the center of his chest. Let the patient sit down and perform an initial assessment. Patients airway is patent, respirations are slightly increased and unlabored, and my partner attached a pulse oximeter and prepared to administer oxygen to the patient. Patient oxygen was 97 on room A, and circulations, radial pulse is rapid, strong and regular. Skin is cool, clammy and pale. Patient conscious and alert to person, place and time, restless and anxious. Patient complained that his chest feels tight and he feels weak. Then my partner administered hundreds oxygen to the patients with nasal prong mask while I asked the patient history and do a physical examinations, and the patient tells that his doctor prescribed nitroglycerin for him. However, because he recently moved into the house, his thing is still packed in one of the box. After confirm no history of bleeding disorder or allergy, I administered 324 mg of aspirin to the patients. My partner obtained baseline vital sign and simple history. The patient remained conscious and alert but is becoming increasingly restless. Then I attach the patient to a cardiac monitor and interpret his cardiac rhythm as a sinus tachycardia at 110 beats per minute. After administer 0.5 mg of nitroglycerin and GTN sublingual to the patients, I and my partner attach the remaining ECG leads and obtain a 12-lead tracing of the patient's cardiac rhythm. As my partner stands up to retrieve the stretcher from the ambulance, I tell him that it looks as though the patient may be having an anterior wall MI. The patient's chest pressure is unrelieved following 2 more doses of sublingual GTN. So I place him on the stretcher and load him into the ambulance. During road to the hospital, continue the oxygen therapy and successfully established of IV abnormal saline with gauge catheter. Risk assessment of his BP revealed a reading of 140 over 80/80. Because the 3 doses of GTN failed to relieve his pain, I administer 2 mg morphine sulfate via IV push. Within 10 minutes, the patient tells me that the pressure in his chest has improved and his pain score now a 3 over of 10 scale with an estimate time of arrival at the ED of 20 minutes. I administer the IV infusions of GTNs at 10 UG minute and perform an ongoing assessment. And the patient condition continued to improve due to road to the hospital. I asked him if he has a history of ulcer, bleeding disorder, recent surgeries or stroke. He tells that other than his high blood and occasional chest pain, he has no other medical problem. I just called the radio to report to the ED and continue to monitor the patient. The patient still tells that he still experiences chest pressure. However, it less severe since his BP remains stable 130 over 84. I administer another 2 mg dose of morphine via IV first. You continue monitors the patient vital sign and cardiac rhythm, and estimate time of arrival at the hospital is 5 to 10 minutes. Upon arriving at the ED at 7:45 a.m., the patient stated that he is pain-free. I give a verbal report and felt of 10-12 lead ECG to the attending physicians that on duty, and following additional assessment in the ED, the patient is diagnosed with an acute anterior wall MI. Following successful treatment with fibrinolytic therapy, he is admitted to the cardiac care unit and transferred to a cardiac rehabilitation facilities in 10 days later. And this is a Levine signs, which means clenching his fist against the center of his chest. That one symptom of chest pain.
So the conclusions is this case report by a patient who had a reasonably straightforward MI that was effectively treated in ED with fibrinolytic treatment following quick pre-hospital care and transport. And the patient had a great pre-hospital treatment because the paramedic worked well together as a team. So as a strong working relationship between BLS and ALS professional is critical to the patient outcome. Although each level of pre-hospital care provider has a distinct understanding of pathophysiology and patient management, it is the collective contributions and effort of all providers that will give patients with the high quality of care they deserve. That's all. Thank you.